My title is Dr. Mark Tomlin. I'm a consultant pharmacist in critical care, which means I work most of my time with anaesthetists in intensive care and theatres. The COVID virus is a severe acute respiratory infection, which is abbreviated as SARS, caused by the coronavirus, in fact, the second coronavirus that we've seen. The virus activates the immune system and kickstarts the body to produce antibodies in order to kill the virus. It's a bit like the starter motor in a car. However, in some people, they're unable to switch off the immune system, and these people end up in intensive care with multi-organ failure. I think it's because many of the body systems are in homeostasis, where two opposing forces or processes are in a balance. I think one of the best examples of a homeostatic mechanism is the clotting cascade. And the one I thought would illustrate this well is the multiple steps in the clotting pathway, which are held in check by antithrombin 3, so that thrombi or clots are not formed where they're not needed. When we get heparin, we augment or enhance antithrombin C, and so tip the balance in favor of not clotting. So that's an example where the homeostatic mechanism is there and we push it one way or another. Okay, I think to really understand this, I'm going to go back 25 years or so to 1998, year 2000, when there was a new drug on the market called Centoxin. Now, the importance of this drug is that at the time, something like a third of deaths in America were due to gram-negative bacteria. So gram-negative bacteria are the ones which don't absorb the gram stain because they have an outer protein coating which stops the stain taking hold. Now, when you get a gram-negative infection, this layer is shed and produces an endotoxin response, a cascade of events which are inflammatory, which we see with gram-negative bacteria. And Centoxin was a human monoclonal antibody against this endotoxin. Now, what we learned from these trials was the importance of selecting the right cohort of patients. If you give Centoxin to patients with gram-positive sepsis, it doesn't work. More importantly, the patient's probably receiving the wrong sort of antibiotics as well, and I think that's crucial. The other thing about this trial is what was one of the first sepsis trial that clearly described the research definition of sepsis, because before then it had been fairly vague. And in fact, in many patients, sepsis was sort of flying blind. You didn't know whether you had a bug, let alone what kind of bug it was. And I think this is important because when patients get to intensive care, they're often passed through the emergency department, maybe onto a medical ward, and they may have received a number of antibiotics. The trial design gave us a clear definition of SIRS, systemic inflammatory response syndrome, which you get when you kick off this process. And then if you cultured a bug or had a very high suspicion that it was infection, that was one of the criteria for giving Centoxin, which was an expensive drug. And if we look at the sort of cascade diagram that we've got here, you start with pneumonia or some kind of chest infection, could be bacteria, could be fungus, could be a virus. And then in the case of gram-negative bacteria, you get endotoxin or exotoxin released. And then there's a whole load of pro-inflammatory markers or cytokines, TNF, tumor necrosis factor, platelet activator factor, leukotrienes, IL-1 and IL-6, and we're going to come back to those later on. Thromboxanes, prostaglandins, nitric oxides, a key component of sepsis, activation of complement. And then that goes on to latter stages, which are so-called counterbalancing anti-inflammatory mediators, light-activated protein C, like IL-10. That then produces edema, tissue injury, microvascular thrombi, which is going to be important in this story, and the inhibition of fibrolysis. And then these thrombi can go on to produce organ death. And that's the whole sort of cascade into septic shock. And that's what we really learned with Centoxin, was that pathway and a clear definition of where we were going. I think the other important thing for me about this study was it established the partnership between pharmacists and consultants in intensive care. Because really we had to work together to go through the criteria before we were allowed to use this expensive agent. And in my hospital, we treated 18 patients with this drug, and we had 12 survivors. Now, that could have been the drug itself, but probably we'd selected the right cohort of patients to get the right sort of antibiotics. Another hospital I know of gave 24 doses and only had 2 survivors. So we also learned that adherence to a protocol is important. Define your criteria, follow them carefully, get the right patients to get the right drug. And, you know, we had a clear definition of what we were treating. And I think that was really one of the importance of that study. If they move forward to about 2004, there's another study that I was very interested in called the Elephant Man trial, or infamously known as the Elephant Man trial. I always knew it as TGN 1412, which is a bit of a mouthful. So this was a study for a drug for cancer patients. Now, in cancer, we may have an inadequate immune system, and many studies have looked at how to boost this. But this particular drug took the brakes off the immune system so it could be fully activated and really have a florid response. However, instead of trialing it in cancer patients who are at the end of their treatment options, this was a first-in-man study, and it looked it was given to young fit males, those with a normal or even primed immune system, which I think was the wrong cohort of patients to try it on. And what we saw with these study patients was an unchecked super immune response with profound inflammation and edema. In other words, if you can't switch off your inflammatory response, you're in deep trouble. Again, it's the importance of choosing the right cohort of patients and the ability to activate your immune system, as well as switch it off or quench it after it's done its job. I think the immune system is a bit like a freight train. It's very slow to start, but once it gets going, it's very difficult to stop. An example of this would be cancer patients. They may have cancer because their immune system has failed to recognize the abnormal cells. Or they may receive later on treatment, which also knocks out their immune system. So they can't start the motor. They can't get the process going. And therefore, we have to shield them from the virus. And indeed, when these patients are in hospital, we often give them prophylactic antibiotics, antivirals, and all sorts of treatments to help their system, which has become immunocompromised. Other patients with autoimmune conditions, for example, rheumatoid arthritis, multiple sclerosis, inflammatory bowel syndromes, they have an imbalance with their immune system. And so their treatment is drugs which knock out their immune system because it's gone into overdrive. So this is where we get steroids, we get hydroxychloroquine, we get tocilizumab, anakinra, sarulimab, all inflammatory modulators. And this is really where the monoclonal antibody story has ended up. There are lots of treatments for these conditions. But if you've treated a patient, they are immunocompromised. So they are going to get secondary infections of all different sorts, which is why we're now shielding those patients so they're not exposed to the virus in the first place. The coronavirus produces an inflammatory response. This then activates the immune system and the production of antibodies to fight and kill the virus. Now, there seem to be some people who have minor symptoms of a cold and fairly vague symptoms because they've recognized the foreign protein, they've attacked it, and they've cleared it out the system. There are other people who seem to have a very large inflammatory response to the virus. Indeed, the virus may be killed off, but the inflammatory process carries on. And these are the patients who end up in intensive care with multi-organ failure. It showed that if you gave a glucocorticoid like dexamethasone, that you could quench the inflammatory response. And so this was the first, and to me, not that surprising trial that showed that steroids work in this condition, which caused great excitement, more excitement, in fact, than other drugs we had tried, which were purely antiviral. So it is not just killing the virus, it's quenching this inflammatory response that is fundamental. Another part of the recovery trial is tocilizumab, which is a drug against IL-6, interleukin-6, which we've mentioned previously. And this has shown that if people have admitted to hospital and they have simple oxygen treatment, but they're not actually that ill, well, they've got to be able to get into hospital, but not ill enough for intensive care, then tocilizumab doesn't work. The Remap Cap study, which I think we'll talk a bit about later, showed that if you got as far as intensive care, then that helped. And in the middle, there is this group of people who slide into trouble. They don't have this profound cytokine storm, so tocilizumab is of marginal, if any, benefit. So we're looking for patients who have a severe inflammatory response to the virus. They're the ones that deal with later drugs, and steroids is an example of that. So far, I think with the dexamethasone story, I think it's important that dexamethasone is one of the most active glucocorticoids with virtually zero mineralocorticoid effect. So I think if we're going to replace dexamethasone with something else, we would use something of a similar profile. And that's where methylprednisolone comes in. It's got a small amount of mineralocorticoid effect, but it is largely glucocorticoid. The difference is not as great as in Dex, but that would be the second choice. If you looked at hydrocortisone, which is a one-to-one effect, so the same amount of mineralocorticoid and glucocorticoid, that wouldn't be my first choice. Prednisolone also has a very profound glucocorticoid effect, and we could use that. And indeed, if supplies of dexamethasone were threatened or methylprednisolone were threatened, we might then go for hydrocortisone as an injection or prednisolone orally, because they have glucocorticoid effects, which I think is key to this, in that it's not just something that raises blood sugars, it's something that quenches the inflammatory process, which is really our aim of this process. We've used a range of doses of dexamethasone for various inflammatory conditions. You know, we've gone as high as 32 milligrams in quenching brain tumor edema, for example. Often we use much smaller doses. 6 milligrams was chosen in the trial, so the evidence base is with 6 milligrams. Now, whether that's the optimal dose, I don't know. We haven't done the dose ranging studies to find this out. Some people have gone as high as 20 milligrams and said this is better, and maybe it is in quenching inflammation, but we must remember that these are powerful drugs which are upsetting the immune system deliberately in the primary event, but longer term, we may end up selecting out fungal infections and viral infections as a secondary event, which we want to avoid. So yes, we don't know the dose. We don't actually know the timing or the duration. 10 days was tried. In some people, that's enough. In others, it seems to be inadequate, and we go on either with more dexamethasone or convert to methylpred, which has been suggested as an alternative. So we don't know the duration. We don't really know whether 6 milligram is the ideal dose. I think I would point out that the nomenclature of the injection is a little confusing, and some might say it should be 6.6 milligrams of the injection simply because that's a whole ampoule. This would be my advocate, because nurses in full PPE trying to work out what fraction of 6.6 is 6 milligrams seems to be an unnecessary waste of effort. I'd rather the patient got the drug, a whole ampoule, and left it at that. I think the Remap Cap trial design was a creative, innovative answer to the fact that we needed to try lots of different agents. We didn't know much about the virus, and we needed some fast results. So most trials look at one drug, maybe 2 or 3, again, and compare it against placebo. But this study said, well, we've got lots of ideas here, we'll try them, and if they prove successful, we'll give them to more patients, and so on, so that we could get a statistical analysis that showed the best outcome. So there are about 9 different arms to Remap Cap. There was aspirin, there was antivirals, there was dexamethasone, hydroxychloroquine, azithromycin, colchicine, all sorts of things were tried. And what we discovered fairly early on was some of the exciting drugs like remdesivir, indeed, and antivirals didn't actually prove as effective as we had hoped. So we stopped recruiting to those arms. And that's quite interesting, because drugs we thought would knock out the virus, we thought would make people have shorter stay in ITU or never reach it at all. And what we found was if you got to intensive care, giving antivirals didn't actually seem that helpful, which plays to this story of the virus may be dead, but the patient has still got a profound inflammatory response, which we must quench. And dexamethasone was one of the candidates that, again, showed promise, so we gave it to more and more patients. And as time has gone on, so we have introduced new drugs like tocilizumab, anakinra, and sarilumab, which again proved to be effective in intensive care, but not necessarily outside of intensive care. Well, I think we can say that outside intensive care, we don't really know the full story, and we're still exploring it. Inside intensive care, giving antivirals doesn't necessarily shorten the length of stay, but giving drugs like steroids and tocilizumab, which quench the inflammatory response, seem to be the ones that show benefit. And it could be that these are patients who have a profound inflammatory response, which they're unable to quench. So we give them drugs to help them suppress their overactive immune system, so that they can get better and avoid consequences of infection, such as edema and inflammation and fibrosis, which may be what long COVID is. There are a number of drugs which will be incorporated into the Remap Cap studies. We haven't said anything about ivermectin yet, but then that's an idea to explore. We have noticed that patients have low vitamin D levels, and it could be that the BAME cohort of people, particularly in the UK, in the Northern Hemisphere, don't get enough sunlight, and so their vitamin D levels of synthesis are lower than required. Or it could be that if we treat the low levels of vitamin D that we are seeing, that maybe that will improve it. And I think vitamin D will be an interesting story for the future.